All right, good morning, everybody, and welcome back. First one back after a big long break, so expect this to be a little rusty. Uh, Fortunately, we are doing really boring topics again today with not much content, so we can just catch up for an hour. Subjects we're covering today are polyphagia, anorexia, and body odors. And anybody new joining us, what we're doing is just working our way through Edinger, pretty much 3 chapters every fortnight. When they're really, really boring, sometimes we squeeze a few more in there. When they're really detailed, we just do 1 chapter and throw in some literature. The next subject is actually much more interesting. So coughing, sneezing, epistaxis, and nasal discharge. So this is where we start to get into a little bit more medicine. So in a fortnight, we'll be covering that one. And I'm going to put Josh on the spot with no preparation, but do you want to cover one of those topics or 2 of those topics?
Sure.
Yeah. So do you want to do coughing or sneezing epistaxis?
Maybe sneezing epistaxis, actually, that'd be good.
Cool. Okay, excellent. So I'll plan to sort of spend about 20 minutes on coughing, and then we'll do 40 on nasal diseases. Because there's 2 chapters in there. Excellent. So that's the next fortnight. But this fortnight, did anybody read the chapters?
I had a quick skim. There wasn't much there.
It was literally about 6 pages.
Yeah.
Total 3 chapters in 6 pages. So let's start with anorexia, because it's something that we do see so often clinically. The reason why I find these chapters hard to talk about is because you sort of say, well, you have a patient presented with anorexia, what are you going to do next? And you're going to do a physical exam and blood test. And the options of where that might take you are so broad that it's hard to kind of talk about this in any way that kind of helps. But when we fast, or when an animal is anorexic, how long before you sort of say, okay, that's a problem? Like, can they skip 1 meal? Can they skip 2 days? What's metabolically, when are we going to start running into problems because of anorexia as opposed to the underlying problem?
I guess 3 days. I don't know if that's correct.
Yeah, you're absolutely right. So the glycogen reserves, the carbohydrate reserves, which are what we use preferentially in a fasted state, so it's the easiest thing for the body to use, it will be exhausted in most animals in 3 to 5 days. That obviously depends on what they've got stored. So all of the animals have got different glycogen stores, depending on, a diabetic patient might have heaps of glycogen stores if we've been giving them heaps of insulin, or be pretty short on glycogen stores if they haven't had much access to insulin, or if they've been a bit deficient. And depending on what else is going on metabolically and their energy consumption as well.
That's interesting that you say 3 days, because that used to be standard in emergency medicine when I first started into it. But I've seen since that you should start feeding earlier than that in critical patients anyway.
Absolutely. So the feeding isn't necessarily to replace the calorie deficit. It's actually to maintain gut health. Because the enterocytes don't actually get much blood supply, they rely on getting their nutrients from the food that's ingested. So you start to get mucosal damage and mucosal leakage and increased mucosal permeability of the gastrointestinal tract even after 24 hours without any food, because of the enterocytic damage. And particularly far down in the bowel, those cells are really dependent on where all the nasty bacteria are, really dependent on enteral nutrition for the cellular nutrition.
Are those cells more dependent, or are they it's just more of a problem if they're unhappy?
That's a good question. I think it just compounds whatever the underlying disease is. So if you've got mucosal damage, you're going to get decreased digestion, absorption, and then returning to normal health is going to take longer. Because if you can prevent that mucosal damage and keep that digestion absorption phases normalized by feeding early, they're going to recover better. So the glycogen starts to run out. At what other stores does the body use as an energy source?
Muscle.
Fat and muscle.
Fat and muscle, exactly. Yeah. So even from like 12 hours fasting, we start to get some ketosis developing. What does ketosis arise from?
The use of ketone bodies for energy production.
Yeah. And which tissues do ketone bodies come from? Not tissues, which macronutrients? Is that the right word?
Fatty acids, the breakdown of triglycerides. I don't know.
Yep, exactly right. Yep. So we get ketones used as nutrients, and we also get those macronutrients, so fat and protein, broken down to participate in gluconeogenesis. So we get glucose production from those macronutrients. I have to look this up every time I talk about it, and I've talked about it so many times. And you know, you learn about diabetes and stuff like that. So it's not stuff that's like I can't remember what that cycle is that happens in the liver. What do you remember what that is?
Pyruvate, that's all I remember.
Yeah, it's all that stuff.
That was first year uni, so that was a while ago.
Yeah, I mean, we've covered it since. I mean, when we were doing sort of diabetes and stuff like that, we've definitely covered it. But I just look at it and then it just goes straight out my head.
Not the Krebs cycle by any chance, is it?
Not the Krebs cycle.
Nitric acid cycle. No, that's urea and
Yeah. Anyway.
I think that's that second year uni, and that was an awfully long time ago.
It's really far ago. Anyway, it's not very important for anorexia, but what we know is that we start to get, when we're not ingesting those nutrients, we're going to use up all our stores of carbohydrates, and then we're going to start to actually lose fat and muscle tissue in the patient. What is like recovery wise? So say you've got a patient who had a TPLO and had a non-steroidal reaction and went off its food. What's muscle atrophy going to do to the recovery of that patient?
Well, to slow it down.
Yeah, exactly. Yeah. So it wasn't a question.
I don't understand why.
Well, they need one of the main sort of focuses and changes in the way we manage orthopedic surgery. We used to keep them really confined and.
Oh, sorry, you're talking. Oh, sorry, I missed the beginning. That was
TPO. Yeah.
Okay.
Sorry.
Yeah. Sorry.
So, maintaining muscle mass is really important for maintaining joint stability, mobility, particularly a lot of medical patients are older patients. And once they lose muscle, they just metabolically don't have the capacity to gain it again. And often the exercise ability to gain it again. So once it's gone a lot of the time. So maintaining that muscle mass by maintaining nutrition is really important for recovery of medical and surgical conditions. If you fast for long enough, other than the kind of metabolic consequences of muscle atrophy and stuff, what other systems might be impacted?
Well, if your blood sugar drops, your nervous system.
Yep. More kind of, I mean, blood sugar should never really get low enough that from fasting in an adult patient, certainly juveniles, that your nervous system's affected. What about the impact of fasting on the immune system?
Yeah, well, that'll decrease its ability to work.
Yeah, exactly. So there's specific parts of the immune system that are dampened down with anorexia, and that's after around about 3 days duration. So specifically, Josh, did you happen to pick this out of the chapters?
Which part?
How the immune system is affected by fasting.
No, I don't think I think I must have. That might have been a bit that I skipped.
Well, unfortunately for you, it was the only interesting bit in all 3 chapters.
I'll go back and read it. It's fine.
So I think it's really interesting because often we're in the process of working out what's going on with these patients, and often it's an infectious disease or a UTI or biliary infection or something like that, and it actually causes decreased phagocytic function. So decreased cell-mediated immunity, and then also decreases immunoglobulin synthesis as well. So it impacts the humoral immunity, the more ability for that animal to mount a more long-term response, but it also decreases the clearance of infection just at the kind of first-line defenders point. So if a patient's been anorexic for 3 days, we're starting to then exacerbate any infectious disease that we're seeing. Interestingly, and not from Edinger at all, but there's the Nobel Prize for, in some category, can't remember, looked at the impact on fasting on, the telomeres on DNA. Yeah. So on like essentially on cell repair and longevity of cells. And in humans, prolonged fasting, so greater than 16 hours, you start to see cellular repair occur, which you don't see. So it almost like wakes the cells up and tells them to start looking after themselves better. So there's survival benefits, and they haven't done longitudinal studies to demonstrate this, so I'm extrapolating, but to prolonged fasting potentially, but we're talking 16 hours, 3 days max. They don't suggest fasting beyond that. So there is where we get the immunosuppression that potentially has some cell benefits in healthy patients, but in our unwell patients with increased metabolic needs, not so much.
Which is rather interesting. It's intrigued me that the current trend towards fasting diets. Most of the ancient cultures, like the monotheistic ones particularly, had fasting as part of their rituals. Like Catholicism, Judaism, I'm not sure that is though. And the ancients weren't stupid.
Yeah. They actually, listened to each other and their ancestors. So there may be some benefits to fasting, but we don't have good data in animals, and realistically a lot of animals are sort of fasted for 12 hours or 24 hours because they're fed once a day in a normal kind of daily in health. So I'm not sure how it applies to animals, but it's interesting stuff coming through in the human world.
Animals don't have all the other lifestyle issues that humans have that will lengthen their telomeres.
Well, I don't know. Eating a fair bit of processed food.
That's true.
Obesity is a big problem in animals as well. So theoretically, they're going to have the inflammatory stuff going on secondary to that. I think Matt pointed out that metabolic syndrome existed. So I think we talked about metabolic syndrome at the end of last year, and Matt said, "Oh, it exists," and then he sent me through like 6 papers about metabolic syndrome in dogs, and it definitely exists. So it
wouldn't make sense if it didn't. Really,
exactly. I think anytime we say, "Oh, that doesn't affect dogs," we're like, Okay, so the other thing that anorexia will do, and this is specific for cats, it will impact the liver's ability to detoxify. So we've all seen cats who start to get their PCV going dum, 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 in hospital, haven't we? What's the cause of that?
Hemolysis, oxidative hemolysis.
Oxidative damage, exactly. So oxidant damage of the red cells, because there's oxidants in circulation, which normally the liver would have processed. So with anorexia, we see decreased hepatic detoxification. And actually, this does relate to the urea cycle, which I also can't remember, but there's an amino acid that cats are, what's the word when an amino acid is an essential amino acid? They need to eat it. They can't manufacture it. If they don't eat it for 2 days, it's a cofactor in that urea cycle that processes ammonia, and we start to see hepatic encephalopathy in prolonged fast in cats that are fasted over a prolonged period because of the deficiency of this one amino acid, and dogs it's not an essential amino acid.
Right.
I can't remember what the amino acid is, but it is actually very interesting that we will see hepatic encephalopathy arising with prolonged fasting in cats.
It's not taurine, is it?
Mm-mm.
That's all, well, it's also an essential amino acid, but there must be another one.
Yeah, I think it's either arginine or ornithine, but it will take me about 40 minutes to look it up. Sorry. So that can be your homework. So what options do we have for managing anorexia?
Well, yeah. Treat the underlying disease.
Yes, ideally. Yeah, exactly. Yeah. Let's start with medical management.
Nausea, if there's any nausea,
Yes.
like I look for symptoms of nausea.
Yeah.
And I guess if you had a disease, underlying condition that was associated with nausea, you could assume it was present, and then
Yeah.
for nausea.
For sure. So what are you going to treat nausea with?
Probably Meropetan.
Yeah, first line. Perfect.
Yeah, if it's not working, on Danzatron.
Excellent. Anyone use anything else?
Well, there's appetite stimulants.
Yeah, for sure. Yeah. So as far as nausea, the only other one that's worth probably mentioning is metoclopramide. So often, if ileus is the cause of the anorexia, getting things moving, metoclopramide has that double benefit. It's not that great at anti-nausea, but it's not that great at prokinesis either. But it's something that we can do to get the guts moving again and create a bit of space for some food at the top end. I can see shadows outside my door. Someone's creeping out. So
and are you thinking, like, just if you see that on an ultrasound, you've got ileus, or are you thinking, oh, they feel like they're gassy? Like, do you make judgment calls on ileus?
I'm spoiled in that I get engaged to do the ultrasound, so I know that there's ileus before I make my recommendations. But signs of ileus might be no stool production. So if they've been in hospital for 3 days and they haven't food, then there's going to be some stasis in there. Not wanting to eat, and it is actually just during your A fast, one of the windows that you put the probe on, just at that cranial aspect of the abdomen, you can see if there's stuff in the tummy, and if they're fasted, they're anorexic, you shouldn't see anything in the stomach. It should be really empty. So it is worth potentially looking at that, and that will often guide my decision. Okay, this dog's had a really bad gastro, it's got inflammatory associated ileus. If we can get that gut moving again and it doesn't feel so full, it's going to be much more likely to eat. The other one we see, particularly gastric ileus in, is pancreatitis. Because it causes really localized inflammation at that pyloroduodenal junction, gastric outflow is often quite delayed. And so if I had a patient with pancreatitis or really bad diffuse gastroenteritis, then I would consider metoclopramide. When I'm worried about foreign bodies, when I avoid metoclopramide.
And you're only using that in a CRI, really? Like, your patient has to be on fluids?
I would definitely do
intermittent.
You would? Yeah. Or a subcut injection. Okay. So if you're managing them as an outpatient, and you're worried about ileus, then I think it's reasonable to do it just because if you clear out the stomach, feed them 2 hours later, hopefully that then the nutrition will get the bowel moving again as well.
What's better is I understand it through with a CRI. My experience as well, metoclopramide works better as a CRI.
I think it does too. And most of the time, these patients if they're not eating, they're probably not hydrating themselves well enough. And I do worry about having them as outpatients. But then again, particularly with cats, they don't eat in hospital a lot. So sometimes we just got to send them home and on day leave or night leave and hope that they start eating. Metoclopramide doesn't really work as a prokinetic from cats, so I'm kind of referring to dogs when I should put that. Good. So they're the 3 antiemetics that I have in mind when I'm trying to get animals eating again. Appetite stimulants. What are our options? What's your favorite option?
Mirtazapine, because it's also an antidepressant.
Yeah. That's a good point. Yeah. Anyone else?
Antihistamine, his name won't come to me.
Periactin. What's it called? Remember the name?
Cyproheptadine, is it?
Periactin's the brand.
Cyproheptadine, I think.
Yes, that's it.
Yes. Yeah. And what is that? What class? Antihistamine. Sorry, Jess said that already. Good. Mirtazapine's my favorite. Of the appetite stimulants, when they tested them, and I think they actually only did, this is probably not a good study to quote, because I think they actually only did meropenem versus mirtazapine, tested them in cats with stage 3 and 4 renal disease, and mirtazapine resulted in increased like weight gain and increased food intake, according to the owners. So it was the one that was most effective in improving body condition in cats, but that didn't compare Periactin or anything. The Edinger chapter says the author's preference is mirtazapine, and that's certainly my clinical experience as well. What about a cat that's in hospital, has an IV port in, and is difficult to tablet? What could you use?
Mirtazalam.
Or diet potentially, but it's not quite as accepted in cats. Yeah, it's a really nice way of just getting the first meal in if you kind of got IV access and need to give them the munchies. Just a little tiny dose of midazolam, 0.1 mg per kg. They're not sedated enough to be impaired swallowing wise, but they're trying to eat everything.
In the subcut, it works as well.
Does it?
So you could potentially do it as an outpatient.
Yeah, cool. Yeah.
But it might be a tiny bit wobbly.
Yeah, I was going to say, I don't know that, because it's like literally inject and then they're like, while you're leaving the cage. So I'm not sure it would have, you'd get the same like munchie response.
You put the food bowl in front of them before you give the diazepam.
Yeah, exactly. Yeah, it works so well. Any others people use? I can't remember. There was one other one listed in Edinger. I was like, whoa, that low dose propofol.
Yeah.
Yeah. Have you used that, Josh?
No, not at all.
Ron?
No, it always is in my mind, but we don't have any propofol in the fridge.
Yeah, nobody really uses it anymore. We've got some up at Northside. It's an interesting thing to try, if you can look up a dose, but not whatever we're called now. Sorry. And so if our medical management of anorexia and the underlying disease fails and they're still not eating, what are we going to do?
Enter like a nasogastric tube.
O tube.
Or an O tube.
Good. Yeah, exactly. So both would be good options. When would you choose an O tube over an NG tube?
You have to anesthetize them for something else anyway.
Yeah, good.
If they're going to be an outpatient potentially,
Exactly. So I think the NG tubes are great for getting a patient through a very short crisis, but we don't really send them home with them. They just take them out.
The NG tube's much smaller, so it's much more prone to blocking.
Much more prone to blocking and very limited in what you can feed them. You can't give tablets through it.
Yeah, my experience has been it's better just to feed liquids through that. Blending cat food or something like that doesn't. They're much more prone to blocking.
Exactly. So it's really, we're quite limited. We often don't get a balanced diet in through an NG tube. There are better options for liquid that have become available fairly recently, but fairly recently being the last 10 years.
Is Ensure thin enough to go through?
I think so.
Yeah.
Emerade is the one I think they're using it a lot in at work. But
yeah.
What was that again, Josh?
Emerade is the one I think they're like, yeah, I don't tend to use a lot of NG tubes, but the like critical care department tend to use a lot of Emerade.
Ostomy tubes, I understand, have gone out of favour.
Which ones?
Jejunectomy.
Yeah, you miss a lot of the digestive phase going straight into the jejunum. So you miss the when food goes into the stomach, you stimulate a lot of the kind of acid secretion, and that stimulates the bicarb secretion from the pancreas, and then the intrinsic factor never gets to bind, and then the B12 doesn't get absorbed, and there's a whole kind of host of things that happen: gastric, proximal, duodenum, pancreas, and bile. You get the gallbladder contraction to help with fat absorption, so you miss a lot of that digestive processes.
The other thing is to understand it's got to be given by a CRI, because if you put too much in, then like in a intermittent feeding, that you'll make them vomit and can be actually fatal, I believe.
Yeah, they're pretty limited. There's very few patients that we recommend them for, and in fact, most of the time, if we have to do a jejunostomy tube, we do a PEG tube, and then run the jejunostomy tube through the PEG tube into the jejunum, and feed through the jejunostomy tube until they're well enough. Then we pull the jejunostomy tube and feed through the PEG tube to get the double benefit through one procedure. So we very rarely go percutaneously straight into the jejunum anymore.
Yeah, because the surgical risk is high as well.
Yeah, exactly. Yeah, and it's just kind of a very much a last resort. And how do you remove them? Do they just form a stoma?
Yeah, they do. If they're in long enough, you've got to give it time to form a fibrous union against the abdominal wall.
Yeah, same as a PEG tube.
Because that's going back decades to my early days in emergency medicine.
I'm sure I've told you about this case. I had a dog that belonged to a human doctor. Josh will recognise this one. That had pancreatitis, and then 6 weeks later came back in for vomiting and diarrhea. And the owner was like, "I want a CT, not an ultrasound. You missed something on the last one." We did a CT, and there's this kebab stick just coming out the side of the stomach. Like, so it went stomach, duodenum, and then came out the body wall. It hadn't actually gone through the body wall yet, but we're starting to see just a little bit of reactive tissue, and it was kind of in the peritoneum.
Wow.
Do you remember this one?
I don't.
Oh, so it belonged to a human general surgeon, and she goes, "Okay, we'll just take it out through where it's poking through. Just pull it." And I was like, "No, we're going to do an X-lap." And she's like, "No, we're not." And I was like, "You're signing a treatment waiver. I'm not doing this." And she's like, "I will." So we did all the sort of legal stuff, because she was like, a flat no, we're not going to X-lap. That would be completely, like, the risk of X-lap is so much higher in humans. Like, this is a very safe procedure. I was like, "No, it's really dangerous." And she's like, "No, it's not." So we did all the legal stuff, and she actually came in and assisted me and a surgeon with the surgery, and we pulled the kebab stick out the side, and then we had a dressing on there, and we fed the dog methylene blue in its food for a few days post-op. And when the dressing wasn't blue anymore, we knew that the hole had sealed over. The dog got peritonitis, never got any, like, it was such a non-invasive surgery, and I never would have done it without that input from the surgeon.
It had a little tunnel with it. Would it just it kind of formed its own little tunnel?
So
it formed a
stoma.
Yeah, which is exactly what the jejunostomy tubes do. And then once you remove whatever's in the lumen of that stoma, the stoma just heals closed. Same as
Crazy.
Yeah.
Did they methylene blue in people for that, or
yeah, they do? And this
I was going to say, whose idea was that?
Oh yeah, it was hers, all her. Yeah, and I've never seen it documented in dogs, so now I tell everybody about it, because I think it's actually a really nice way to see where the PEG tube like holes have closed and stuff as well. And then you don't have to be so sort of worried about peritonitis and stuff once it's closed over. It's not leaking anymore, and you can kind of just go, okay, on your way. Very interesting. Okay, so O tubes are probably, now that we've got the nice little introducers and stuff like that, very non-invasive procedure, very well tolerated by most patients, and easy to replace if they pull them out after it's formed a stoma. So they're probably my preference, and you can put a pretty wide tube in, so you can get tablets, and you can get crush tablets and stuff like that through. Everybody's familiar with O tubes, I think. Okay, and then once we've got the feeding tube in, is there anything else we need to talk about with anorexia? We don't need to worry about anorexia once we've got the feeding tube in.
No, I guess you should either have an idea of why it's anorexia or you're hunting for it. So.
Yeah, exactly. And it's often that stuff like CKD and stuff that's kind of, yeah. Okay. So the next subject is polyphagia. So the opposite. So what might cause, not sort of, we might as well do just diseases. What causes polyphagia? Diseases and physiology. Go ahead, Jeff.
Iatrogenic corticosteroids.
Yes. Yeah.
Or phenobub.
Yes. Good.
The chapter was really, broke it down into primary and secondary, which I'd not seen before. I thought that was pretty good.
It's actually a really nice structure. Do you want to explain that?
I think, look, in Labradors, it's instinctive. In Labradors, it's instinctive.
Yeah. So yeah, Josh, do you mind explaining what primary versus secondary polyphagia is?
Yeah, primary was is to do with the is it the satiety centers or basically the brain. So it's similar to other primary and secondary endocrine diseases, but if a primary polyphagia is when the brain is affected. So if there's a brain tumor, brain inflammation, trauma, anything that's affecting the that drive center for appetite in the brain. And secondary is basically everything else that could be triggering that center outside of the brain.
Yeah.
Cats hypothyroidism.
Yeah, so that's going to be a good example of secondary. So it's kind of probably nice to break down secondary into appropriate polyphagia versus pathologic polyphagia. So what might be very appropriate to have increased appetite, cause an increased appetite in a patient?
They've got like
growth, pregnancy, lactation.
Yeah.
Yeah. What about puppies versus adults?
Growth.
Growth is very energy hungry.
Recovery.
Yes. Yeah.
Or like being underweight, like a period of decreased food access.
Yeah, good. So calorie deficiency, and then there's another cause of increased calorie consumption.
Hypothyroidism would be.
It's a good one, but it's pathologic. We're still in
increased activity.
Yeah, exactly. Exercise. So if they're working dogs, they're going to need more food than a lounge dog. I just got guilt because I've been watching Muster Dogs and I've got a Kelpie. She would be so much happier doing that. Okay, so let's move on to pathologic causes. So hypothyroidism, Jeff mentioned. We've talked about some drugs that will cause it as a side effect. What about what else? Give me some more. You do it.
Like Cushing's is a big one, probably the biggest one, I'd say.
Yeah, most common for sure.
Acromegaly.
Diabetes.
Good. So what is the cause? What is the cause of polyphagia in hyper A?
I don't think we know.
Good. Very good. It was a trick question. What about diabetes?
Well, you don't have access to glucose, so I guess it makes you hungry.
Yes. Yeah, exactly. So they're calorie deficient. So the glucose is getting into their bloodstream. It's not going any further. There's a big wall around it. So decreased energy supply in diabetes. What else?
Malabsorptive diseases.
Good. Like?
EPI.
Is that a malabsorptive disease or a maldigestive?
Oh yeah.
Oh.
Maldigestive.
Good.
Malabsorptive, like.
EPI is a great one, though. My God, yeah.
Great one.
I get so hungry.
Well, small intestinal diarrhea of any sort, probably.
Yeah.
Yeah, like Giardia can, I think, coat the enterocytes and like protein losing enteropathies, those kind of things as well.
Yes. Yeah, for sure.
The lymph one that you get in the intestines. Oh gosh, the silky the one that's silky skin.
Yeah.
That one.
Massive external parasite infestation, perhaps.
Yes. So
Like-
nice.
Oh,
which we don't see anymore. But
The worms are getting resistance. The worms are taking over the world. It is actually more local being the north side of Sydney. Like where I've had a couple of dogs with hookworm. I'm like, what? I haven't
which
had
worms are you saying? Hookworm?
hookworm? Yeah.
Yeah, I saw a hookworm recently as well.
Mhm. They're resistant.
That's like the second one in my city career.
Yes. They're developing resistance for sure.
Is that it's not a Simparica trio?
Ooh, I don't know what that is.
Yeah, I'll have to look that one up. Okay, oh good to know.
I think I'm working as a GP. Those don't have the tapeworm, but it does give protection against hookworm and whipworm, I think.
As long as they're not resistant. So I think what's coming out is there's like a round of resistant worms that are just being passed around at the dog park.
Wow. Okay.
I mean, there was resistance in greyhounds for years against with hookworm.
Yeah, and we see it in sheep, like in livestock, don't we? It's just with that kind of population density, we just almost cleared worms from the population that I see, and it's just starting to come back out again.
Big deal in livestock from memory. Like they rotate the paddocks all the time.
Yeah.
Yeah, and they don't, they shouldn't just be routinely using antiparasitics. I think we need to question our small animal.
Definitely.
Yeah, interesting.
Practices.
Yes.
It's because the dogs in the northern Sydney are on tick prevention every month, which has these
yeah, they're all on all the all-in-ones. Yeah.
Oh, interesting.
And they go to the dog park. It can't be a problem with dogs that don't go to a high density area like a dog park.
There has to be like mingling of poo for this to happen.
I wonder if a lot of the dogs are coming from the country, being brought in and then kind of being brought into these inner city areas and bringing new populations in.
Yeah, but I reckon that there's less likely to be resistant bugs out in the country for small animals. Like, yeah.
Are they using the same stuff? I wonder. Maybe not.
No.
Well, they're just using it less. They're not very good at it, giving it once a month or whatever.
Whipworm is something I've seen in working dogs where they've been living in the same hollow log that every generation before them for the last 100 years.
The eggs last for ages in the environment. Yeah.
But they wouldn't be on tick prevention out there.
No.
No need.
No. I wonder if they're resistant though.
Oh, probably not.
No. So I think the tick prevention thing is that we're overusing certain classes of antiparasitics,
yeah, but
I was wanting to say parasiticides, but is that right?
It's
would be not an anti-parasiticide.
No. I was glitching. It's a double negative.
Yeah, well, the alternative is worse, tick paralysis.
Yes, yeah, well, except you can use tick prevention products that don't have the plus. They don't have the parasiticide in it.
Yeah, I think I'm not doing that.
You're not doing that? Yeah.
I'm going to start doing that.
Yeah, it's an interesting point. I hope somebody's monitoring it. Because I sort of see, because I deal with quite a few cases and often like gastro cases, I sort of hear stories from people, I had a hookworm case and stuff as I go around.
But they have to use the yearly heartworm injection, which I don't love. The month heartworm is good, I like anyway.
Yeah. I don't know enough about the products, but somebody smart should look at that.
They should.
Yeah.
Well, what the reps are saying, and they've done some sort of studies, uncontrolled, I think. The reason for heartworm in Sydney is people have been less efficient with giving me preventions.
Oh, that's what I wanted.
Missing a few weeks here and there and things like that. But back in the old days, when we didn't have really anything decent for heartworm, 1/3 of dogs in the Hawkesbury area would have it.
Wow.
100% in Brisbane and 100% in Darwin.
Wow.
And when Cyclone Tracy, I was working in Queanbeyan at the time, and a lot of military dogs pets belonging to service personnel who were transferred back to Canberra brought their heartworm with them.
Yeah, right.
And I saw heartworm in a dog that was sleeping alongside a Darwin dog.
Oh, wow.
It's interesting. Obviously, it didn't get it from the dog, but it must have got it from the mosquito that got it from the dog.
Yeah. One of my colleagues just echoed a dog, did an echo in a dog with heartworm, and it's one of the most exciting echoes I've ever seen. You could see the worms.
I mean, I had the same experience with Frontline years ago, and people used to say, "Oh, there's resistance to it." So the company rep came around and said, "All right, you get a resistance case, we'll investigate it." And I thought, beauty, we'll put an end to this.
Yeah.
Every time a client came in and said, "Oh, it's resistant to Frontline," and I questioned them, I found there was a compliance problem.
Yeah.
And it was getting so frustrating because I could not send something to the company because they were all compliance problems.
Yeah. I am guilty. I just booked my doggy in for desexing, and they're like, "Oh, when was the last heartworm?" I was like, "Oops, yeah."
It's yeah.
Oh dear.
Tick prevention, you're fine.
They're on tick prevention, but I don't. Okay, we went off track. Sorry, worms. Cause of polyphagia. Lymphangiectasia, Bron, was the lymph thing that you were thinking of?
Yes.
Yes. So when you've got pressure in the lymphatics pushing stuff into the gastrointestinal tract, the flow is going in the wrong direction. It decreases absorption of nutrients because things are going out, not in. And what nutrient is absorbed by the lymphatic vessels?
Oh.
Fat.
Exactly. Yeah, exactly right. So if you don't have fat absorption, you lose a lot of the caloric component of the food that you're eating. So EPI is a great one that Bron mentioned as well. So how does EPI decrease cause polyphagia?
You can't digest protein.
Good.
And and fat, and then you can't absorb them because you can't break them down small enough to be absorbed.
Excellent. What are the enzymes that break down protein from the pancreas?
Protease. Is it?
There's proteases, but they don't necessarily come from. Protease is kind of the class.
Amylase.
Yes, excellent. Amylase. Yeah, excellent. And the one that breaks down fat?
Lipase.
Thank you. We're starting soft, first one of the year.
Great.
Okay, give me another condition. It is so what about a dog with insulinoma? Hungry or anorexic?
So they can't. They've got no glucose.
Really hungry because it'll be dropping the blood sugar all the time.
Good. Exactly. They've got heaps of stores, but metabolically they can't access them because they're in an anabolic state. So their blood glucose drops, triggers the satiety center, and they're ravenous all the time. So hypoglycemia is another trigger of polyphagia. What about other hormones? Any other hormones that might trigger polyphagia, say in an entire female?
Oh, estrogen or
One.
Progesterone.
Good.
progesterone.
Yeah, progestins, exactly. So animals that are on progestin supplements, I don't really know if we use those, but you will get intermittent polyphagia. And appetite will vary in a bitch's cycle depending on progesterone levels. We know about benzodiazepines and antihistamines because we talked about those in anorexia. And that's pretty much it for causes of polyphagia. Does anybody want to cover anything specific in polyphagia? Or are you just desperate to move on to body odors?
Not
I'm
really.
curious about body odors, I have to say.
Sorry.
I'm very curious about the body odors topic.
It was absolutely nothing informative in that chapter.
It was basically skin stuff, wasn't it? I
was.
like, oh,
Yeah. I remember it being actually like getting some little nuggets of gold the last time we went through this, but no, I can't find them this time.
I just remember making lots of jokes.
Yeah, I think it was funny, but not actually.
Someone who was asked to write that chapter in Ettinger, and they were like, we're going to ask you to write a chapter. And you're like, oh my God, thank you so much. You've got body odors. Like, that just, I thought it would be, I don't know.
Do you know what?
It'd be an honor, but
I'm sure everybody's across this already, but the new Ettinger comes out in a week.
whoa, really?
Yes.
Kept
So
pushing
do
it
your
back.
pre-order.
Oh.
And I will be very interested to see if they've expanded the chapter on body odor. We might have to revisit this.
Revisit this in 2 weeks.
Yes.
Okay.
Like a direct review comparison. I don't know if anyone's doing that. So
No, I want to see what edits have been made.
Severe dental disease.
Dental disease, good. Okay, so I think probably the approach, the chapter was absolutely uninformative, but I think probably the approach is let's talk about diseases that you can actually, the smell can help you with guiding your diagnostics. So you have a patient present with halitosis. What are you going to be looking for? Dental disease, number one.
Upper GI disease.
Good.
Nasal, like upper respiratory disease. Even pneumonia, I guess, if there's pyrexia or maybe a cough.
Yeah, very good.
If it's
Also renal disease and diabetes, depending on the smell.
Very good. Yeah. And they're all different, and you can't really write about that in a textbook, can you? But
and some people can't smell. I'm not very good at smelling the difference, but I've worked with nurses who are like, "Oh, that's diabetes," just by smelling their breath. Yeah.
Yeah. I can't smell it. I can't smell ketones. Can anybody?
Urea would, like renal disease. Yeah. You can certainly smell humans that way.
Oh yeah.
Yeah.
I've never tried.
Walked by a fellow who was on a kidney machine, and he was due that night.
Oh right. And he knew.
Wow.
Someone had smell off his breath.
Yeah. Wow. Yeah, no, I can't smell diabetes at all, but certainly uremic breath is quite distinctive. Often they've got dental disease as well and ulcerations and stuff like that, which makes it a little bit cloudy in the smell department. But pneumonia you mentioned, Bron.
Yeah.
What sort of, how do you describe a smell in words?
The pussy sort of a smell, like
it is, isn't it?
Yeah.
And what I want to sort of really pin down is that's anaerobes.
Ah.
Yeah. So that abscess smell, that really like one that hits you in the face, if you get a dog that's breathing that, it's usually an anaerobic infection, and it can actually help you say, okay, we probably need some metronidazole because most of our other antibiotics don't get to high enough concentrations in areas that anaerobes grow in, because there's not great blood supply when anaerobes are growing. Does that make sense? So if you've got an anaerobic infection in the lungs, it's obviously not in an air pocket. It's in a kind of closed off abscessy kind of area. But then obviously dental disease will make that a little bit murky as well. We talked about pneumonia, gastrointestinal disease. So gastric ulceration and bleeding into the stomach has quite a distinctive smell, I find. And I often have people say it's like a metallic smell, and to me it smells like anal gland without the kind of fecal stuff. Like it's quite a tangy smell. Sorry, this is really gross. What about other than oral smells?
I have had 2 dogs present to me in the last 2 months for their bad smell. So
interesting.
It is interesting, yeah. The one was a pussy wound on its face.
All right.
And just didn't notice this huge wound on the Staffy's face until the smell. And the other one was dermatitis, so obviously dermal, but
I think it's quite a common, when I was in general practice, I think it's quite a common thing. Like,
yeah,
my dog smells and they haven't done the investigation of where the smell is coming from. That's your job.
Yeah, no, I don't want to touch it when it smells like that.
Skin, ears, feet, and bum. I think once you've crossed the mouth off the list.
Yeah, good. Skin, ears,
feet, skin,
feet. Yeah, good. And bum. Yeah, good. I think infected urine has
urine. Yeah, true. Well. That's true, because there's often like a bit of incontinence as well.
Exactly. Yeah, that dogs often are a little bit smelly, and the owners might report being able to smell the wee where previously they haven't been able to.
Yeah, urinary tract infections have a classic smell.
Yeah, for sure. I've got one poor nurse who's got the most this dog's got a urinary tract infection that is just camping out somewhere in its urinary tract, and it's completely sensitive to clav or amoxicillin. She gives them amoxicillin or clav, and then a week after she takes it off, it's reinfected again, and we can't find where the organism's camping out. But she can smell it. She knows exactly when the dog needs to go back on antibiotics, and she cultures and does everything right. But it's been like 2 years of the dog being antibiotic. Yeah, it's really bad. It's had like vulvoplasty. It's had like really thorough investigation. It's been to SASH.
Oh no, that sucks.
Yeah. But yes, it's the smell that triggers her every time she's like, no. So hemorrhagic gastro, very distinctive.
Parvovirus has a classic smell too.
Yeah, I don't know. I think it's a hemorrhagic gastro smell though.
Yes.
Yeah.
Smell. Yeah.
And because most of the hemorrhagic gastros I see aren't parvo. Yeah. It's pretty distinctive.
HGA.
Yeah. And then the other thing is sometimes owners are feeding their dogs weird supplements. So like certain fish oils and stuff like that will make the dog smell fishy. And that's the only other thing I can really think of that's a differential for weird smells.
I'm always after, I'm really want someone to delve deep into anal gland issues, because they are sometimes the bane of my life and nobody ever wants to. So I'm excited about anal gland issues.
Yeah, and general practice is a bane of my existence as well. Oh God, dealing with anal glands, seriously.
And they never get referred. Just always
never.
have to deal with them.
Yeah. Yeah, I actually remember anal glands being very annoying and looking for papers and going, there must be a better way
it's like it's such a dearth of information. What is normal? You know, I've got my own anecdotal theories, but there's no evidence to back them all up, you know?
No, exactly. Yeah. And therapy-wise, I felt like I was just making
If they don't get referred to universities, there won't be any literature on them.
Yeah.
Oh, I think people are trying to refer them. Nobody wants
I learned that lesson when I moved from America to England, that in America they used to say that diabetic ketoacidosis was often fatal. And yet then I went to a general practice in England and we saw quite a few diabetic ketoacidotics, and they didn't die. It pulled them through.
Yeah.
So
Wow.
it's manageable. And the reason that the universities were saying that is because the only ones that got referred were the really bad ones.
Oh, that's interesting.
And of course, they had a higher death rate. So what
Yeah.
they're seeing in the universities are a select population.
Absolutely. I think the IMHA outcomes are really impacted by that as well, actually, because we see a lot of IMHA in general practice that aren't crashing and burning and needing transfusions, and they're quite stable and easy to manage.
Mm.
Whereas the ones at tertiary referral centres are the really sick ones.
Pretty much all the new treatments that they're researching are, again, they're kind of like last line things. So
Yeah.
all the papers coming out, like for I think up in Queensland, there was one on IVIG recently, and that again showed a very poor outcome. But it was like, after their third or fourth transfusion, and they were doing
50 grand.
already doing pretty badly at this stage. So
yeah. Yeah, that's a shame, because that will impact prescribing. Like if they had spent however many hundreds of dollars on IVIG before the transfusion at the very beginning of that, because we had really good outcome data.
Yeah.
Yeah,
it's so interesting.
To do that and save the
I think humans, they jump to it way earlier, don't they?
Oh, straight up. Yeah. They use it all the time. Yeah.
Oh.
Yeah, one of my colleagues who's a doctor, friends who's a doctor, is appalled that we don't have access to it. He's like, it's so first line. It's so essential.
I think, like there was a great XVIM lecture on IMTP in humans as a human doctor, and the stuff he was talking about, like, doesn't even reach for immunosuppressive medications until like.
It's so interesting.
I was just like, wow, okay.
Yeah.
Anyway,
I could.
And kids, they just don't do anything. That was interesting as well.
Yeah, for sure. And most of the time, thrombocytopenia in adults or all kids actually is associated with hepatitis, and they treat the hepatitis, and then the thrombocytopenia goes away. Or renal disease is the other one, like the platelets get stuck in the kidneys for some reason. It's so interesting. Like there's subtypes of thrombocytopenia, and often they're not associated with bleeding. Like majority aren't associated with bleeding. We've digressed, and it's time to finish. All right. So in a fortnight, we'll see you back, and I'm going to do 20 minutes on coughing as a presenting sign. So we'll talk about where the cough receptors are, different diseases, and localization of different types of cough. And then Josh will talk all about nasal diseases and discharges.
Sounds like fun.
So much fun. Thank you. Welcome back, everybody.
Thanks, Anna. Thanks, everyone.
Thanks. Bye.
Bye. See you, Natalia.